So as I was saying, I'll just talk very briefly about some basic concepts of cancer and some of the new advancements that we have in treating cancer, and some concepts as to how these drugs work and why we choose these drugs and so on and so forth. So if you have any questions, please interrupt me, ask me. It's just an informal setting. So having said that, I don't think there's sorry, go ahead.
Is this talk more geared to people who have primary liver cancer or mets? Does it matter?
Honestly, my talk, I've just kept very general in terms of cancer per se, and just general concepts of what it is, how we treat it, how some of the newer drugs are developed, and why they work, how they work. So some situations it may, some may not. I think that's a great point, and that's why I said, these are very general topics because I didn't want to limit it to one particular, topic and be so confined to that, depending upon, I'm sure everybody may have other questions that may not pertain to that very narrow topic itself. So if you have any questions, again, please interrupt me and, ask me. So as I was saying, the word, the cancer, I'm not sure there's any other word that starts with the C that's any more scarier and then brings in as many more questions when one hears about that. So all the way from what is cancer to what causes it, what we can do, and so on and so forth. But just talking about what really is cancer. So to keep a very simple definition of this situation, this is a condition where the cells divide abnormally. As we know, our body is made of billions of cells. Now, all these cells, they divide, they grow, and they are programmed to die at a certain time. Somehow, if these cells are able to evade those mechanisms, they grow in an unregulated fashion that leads to tumor or development of cancer, and over time, it can invade to different parts of the body. This is a cartoon that just describes what I was talking to you about. So on the top, we see a normal cell division. So those are normal, healthy cells. They divide and multiply, and as time goes by, the old or the damaged cells are supposed to, die in a regulated fashion. In the bottom, as we see, because of some changes, they call it mutation. Mutation simply means a change in the DNA of the cell. So the DNA is the code that is embedded in the nucleus, which we can call it as a computer that programs all the cell functions. So the DNA has a code that tells it when to divide, how to divide, how fast to divide, and when to die. If there's any change in that DNA or the code, that can lead to unregulated cell growth, and the cell starts multiplying and they don't die in a programmed fashion, and that can over time lead to uncontrolled growth and development of cancer. And the change in the DNA can be caused by many things: exposure to chemicals, exposure to radiation, some familial genetic risks that can change the code of the DNA. So all those things can basically affect the code of the DNA or the computer that leads to an unregulated growth, and they just grow in a renegade fashion, causing trouble. Again, what is metastasis? Again, I'm sure many of you may know all this, but just to define what that really means, as those cancer cells start growing, they can spread to different parts of the body. As I think this diagram shows, all the cells that we have in our body are surrounded by blood vessels. They can invade into the blood vessels or lymph channels, and then can travel to different parts of the body. And as they grow there, they can start, as they reach different places, they can start growing and seeding there. Different types of cancers. Often I get asked, what is leukemia, what is lymphoma, and what is carcinoma? To keep things simple, as some common names suggest, lung, breast, we use the word carcinomas. The cancer of the blood, in simple English, is called leukemias. When the cancer is originating from lymph nodes, we call that lymphomas. Fat, muscle, bone tissue, skin, we call it sarcomas. And then again, then often based on the organ where they develop from, colon cancer or uterine cancer or prostate cancer. So what are the options for management of cancer? This is a small list. This list could go on, but some of the common things that we use are surgery, chemotherapy, radiation treatments. There's a lot we hear about targeted therapies or biological treatments, hormonal treatments, bone marrow transplants, interventional radiology procedures, and I'll have Dr. Martinez talk more about that part there. But rather than going into detail of everything, I'll just limit to chemotherapy and some of the newer targeted and biological treatments. Okay, so what is chemotherapy? In simple terms, chemotherapy is the use of some chemicals or drugs which destroy or kill cancer cells, keeping it very simple. How does it work? Now, these medicines, they work on all cells in the body that divide rapidly. And the reason we use that principle is the cancer cells we know divide very rapidly. So the point being that these chemicals or drugs can go to those cells, and hopefully those are all rapidly dividing cells, destroy them. However, we know that cancer cells are not the only cells that divide rapidly. There are some other cells in our body, our skin, the lining of our mouth, or lining of our colon or food pipe, blood cells, they all divide rapidly too. So the chemotherapy medicines cannot differentiate between the healthy, rapidly dividing cells or the cancer cells. So that's where the collateral damage or the side effects comes from. So they are able to kill the cancer cells which divide rapidly, but along with that, some of the healthy cells also get destroyed. And in doing so, what happens is as I was saying, hair follicles or hair cells, so a person could lose hair. The lining of the mouth, those cells divide fast too. So a person could have some mouth sores. The lining of the colon, those cells divide fast too. Some diarrhea could be an issue with that. Blood cells, they divide fast. So when those cells are killed by the chemotherapy medicines, one can lead to lower white cell count or red cell count, as we call as anemia, developing anemia. So those are all the, unfortunately, collateral damage or side effects that comes along with using chemotherapy. Now, how is it used? Depending upon the situation or type of cancer one may have and the strategy that is being devised to treat that cancer, the chemotherapy may be given at different times. Sometimes the cancer cells, when they are diagnosed or when the cancer is diagnosed, it might be big enough for the surgeons to resect it. So we often use some strategies where we give some chemotherapy type medicines or chemotherapy medicines to shrink them, making it easier for the surgeons to do the surgery, and that's what we call as neoadjuvant treatment. So neoadjuvant means giving chemotherapy treatments before a definitive therapy, which usually is surgery, sometimes radiation treatments. Adjuvant treatment or adjuvant chemotherapy describes the situation where a person is diagnosed with cancer, they had a definitive therapy. For example, let's say stage 1 or I should say stage 2 breast cancer, they had surgery done, and after the surgery is done, if there are indications for treatment or chemotherapy treatment, when we do chemotherapy in that situation, we call it as an adjuvant chemotherapy. Sometimes in certain situations, chemotherapy medicines are given along with radiation treatments. We call it as a radiosensitizing treatments. In these situations, we give very small doses of chemotherapy treatments because their main goal is to potentiate the effect of radiation treatments on the cancer cells. So the cancer cells become more sensitive to effect of the radiation when we add small amounts of or small doses of chemotherapy that we use in often cervical cancer or head and neck cancers. So we call it a radiosensitizing treatments. And in situations where a person has advanced cancer and our goal is to ease the symptoms, we do give chemotherapy in those situations too. So sometimes we call it as a palliative chemotherapy. How is it given? There are many ways of doing it. These are 3 common ways. I'm sure you all know. First of all, intravenously, just an IV or a port a person may have with an IV tubing and a bag. Intravenously, the chemotherapy is most often or most commonly given. Sometimes it could be in the form of a shot given in the skin. And nowadays, we see more and more chemotherapy medicines being given or being available in a pill form, making it that much more convenient. Then there are some other less common routes of giving chemotherapy. Sometimes it's given directly to the abdominal cavity, intraarterial, given directly to the arteries, and so on and so forth. But these are 3 common ways these treatments are given. Okay, what does it do? Depending upon the type of cancer and the stage, the goals of the treatment and what we expect from the treatments could be different. In certain situations, it can destroy all the known cancer cells and getting rid or sterilizing a person of all cancer cells. So we are going for a curative intent in those situations. So the cure is, of course, one. Depending upon, again, what stage, what type of cancer we have, the chemotherapy treatments can help us put some brakes on the problem, can help in controlling the cancer cells, and also in terms of easing symptoms. In situations where the cancer cells have invaded into, let's say, skin or soft tissue or some organs or invading into the nerves, giving chemotherapy treatment to shrink them, and in doing so, taking pressure off those nerves or tissues can also help off with the symptoms too. Having said that, as we talked about, so chemotherapy approach is a more shotgun approach. You try to kill every rapidly dividing cell. But having said that, that's not necessarily the most effective approach. So the goal is how we can refine treatments, how we can target treatments, so we can seek out the cells which are the problems, and in doing so, somehow trying to spare the healthy cells. So this cartoon shows all the attempts, and I think, as you can see, everybody's involved in the research, all the from humans to cats to little prairie dogs there. So what is targeted therapy? As I was saying, chemotherapy is a shotgun approach. Every cells that divides fast, we want to destroy them. So targeted therapies are drugs or medicines that can block or slow the cancer cell growth by seeking out some defined markers and targets, and in doing so, preventing the collateral damage to the healthy cells that comes along with systemic chemotherapy or conventional chemotherapy. So we'll talk a little bit about what those different targets are, but those targets could be the growth signals or the blood vessel formations and so on and so forth. But the basic definition of targeted treatment means define a target, find it, and try to reach there and destroy the cancer cell. So in a targeted approach, as you can see, there are two essential components to it. We need to have a target, and then we need to have a bullet or an arrow that can reach the target. Okay, so what are the different bullets or targets that we have available right now? So mostly they could be a small molecule. Small molecule on the left side, these are usually pills, and we'll talk about those a little bit, or they could be antibodies. Antibodies are proteins which can seek out a certain marker on the cancer cell. So it's kind of a heat sensing missile. It can seek out the target on the cancer cell and go directly there. And vaccines, we'll talk a little bit about those too. So these are three common types of arrows or bullets or vehicles that can be used to seek and find those targets on the cancer cells. So arrows are one component of the target treatment. Let's talk about what are the targets. Now, as we were talking about earlier, the difference between a normal healthy cell and the cancerous cell is there are some unique properties of the cancer cells. And that's where the research is going towards nowadays, to find out those uniquenesses in those cancer cells. Now, the cancer cells we talked about, they can evade the normal surveillance mechanisms, and by doing so, they can divide unregulated. So some of the targets that are being used are the processes that happens in a normal healthy cells that transform into cancerous cells. And some of those targets are growth signaling. We know that there are some signals or growth signals that come to a cell, any cell, that makes them divide fast. So if there is some interference with the growth signals, they can become cancerous, so that becomes a target to develop some treatments for. Evasion of cell death, as I was talking to you about, these cells can evolve and employ mechanisms to avoid or evade cell death, so that process becomes a target. And lastly, increased blood vessel formations. And we'll talk about that too, that as the cancer cells grow, they need more nutrition, and they get so by getting new blood cells made so they can divide faster. So we'll talk a little bit about different targets and the different bullets we have to take care of them. So coming to growth signaling, on the top, as you can see, that yellow, those markers there, the way to look at those would be they're a switch. So there is a switch, and to that switch, that little, the blue thing here, right up there, I'm not as tall as Brandon, but in that blue thing there. So let's say that, the yellow markers are a switch, and that blue protein comes and turns the switch on, and then the signal is sent. So this thing gets turned on, you can see a little aura behind it, and this is the signal goes to the cell, and that makes them divide faster. So that's what a normal healthy cell would do. So what the cancer cells do, they can develop one of three mechanisms. They can make more of this blue protein, which is also called a growth factor. This is what we are talking about right here. They can start making more of those, and what that would do is they will keep on turning the switch on, so the cancer cells will continue to grow. Or they can just have too many switches. Instead of having few, they can just have too many switches. So instead of one switch turning on the whole circuit or mechanism, too many switches there. Or in more technical terms, they'll call overexpression of growth receptors. Simple English, just too many switches to turn the growth signal on. Or there could be some mutation, as we were talking about, a change in the code or the DNA code of the switch. So that switch always remains on. So in other words, the cell is constantly getting a signal to divide or divide and divide. So these are three different mechanisms where the cancer cells can interfere with the growth signals, and the growth signals are always turned on and the cells are dividing. So there are ways and there are medicines that interfere with this mechanism, and we'll talk about that. Okay, so Gleevec, I'm sure many of you may have heard about. Gleevec is a pill that changed how we treat chronic leukemia or chronic myeloid leukemia. Chronic myeloid leukemia is, in simple English, a type of blood cancer. It was unfortunately an aggressive disease. The treatments would involve heavy-duty chemotherapy followed by a bone marrow transplant, an allogenic bone marrow transplant. People who were diagnosed above the age of 50 would not have access to bone marrow transplant. One doesn't do that. Allogenic bone marrow transplant was essentially a fatal disease. In late 90s, Gleevec, the pill, was developed, and it just changed how CML is treated. So CML now is a treatable entity. It used to be an average survival of a person diagnosed with CML somewhere around 3 to 5 years, even with bone marrow transplant. Now 10, 12, 15, 20 years. In fact, a friend of mine who was 32 when he was diagnosed with CML in 1999, he was one of the first few enrolled in those trials, is doing just fine. I know why, but he's practicing North Dakota. I've asked him to move, but he's doing just fine in North Dakota. So what Gleevec does, as the slide says, so the target here is growth signals, and the arrow is a small molecule. As we talked about, there are 3 arrows. It's a small molecule, it's a pill. So these are the switches. This is a cell. These are the switches that turn the growth signal on, and the cell grows. So Gleevec, this little thing there, it can enter the cell, and from inside the cell go and bind to these markers or these switches, and doing so turn off the growth signal to the cells. So, and by doing so, all these leukemia cells die. And since Gleevec is so specific for the switch only in the leukemia cells, there is very minimal, if any, collateral damage by taking Gleevec. So one example of targeted treatments that is using a small molecule as an arrow or a bullet and is interfering with the growth signaling. Other example, a drug called Herceptin. I'm sure many of you may have heard. Herceptin is a protein or an antibody against HER or HER2 receptors. So HER2 is a receptor or a marker seen in 20% of all breast cancer cells. What it does is, once again, it promotes the growth or growth of the cancer cells. So Herceptin, this purple thing here is the monoclonal antibody. So monoclonal antibody is a protein, kind of a heat-sensing missile that will go and bind to the target that it's supposed to seek out. Herceptin is supposed to seek out these targets, which are HER or HER2, seen primarily on the breast cancer cells. So it's given intravenously. So what it does is, once given intravenously, it will, of course, go through the bloodstream and find these targets and bind to them, and in doing so, stop them from sending that signal to the cell from growing. So the difference between a monoclonal antibody as an arrow is it comes from outside the cell, If you remember the Gleevec we talked about, the pill, it came from inside the cell. The whole purpose is they are trying to somehow attack this switch, and in doing so interfere with the growth signaling. So again, Herceptin is a protein, seeks out only the markers on breast cancer cells. It has changed how we treat breast cancer, and unlike chemotherapy, no hair loss, no blood cells dropping, no nausea, nothing like that. So we can avoid all those side effects of chemotherapy. The second target that we use is angiogenesis, in simple English, increased blood vessel formation when the cancer cells grow. So as this slide shows, this is a small tumor, and as it wants to grow, it needs more nutrition. It needs more blood supply. So it secretes certain chemicals or proteins, we can call them angiogenic factors, that stimulates the blood vessels to grow. There's a spout, and the next thing you know, this tumor is just covered by small blood vessels which can provide nutrition to it. And we do know, and there are experiments done where they took mice, and the mice which did not have these factors, and they injected cancer cells into them. Those cancer cells didn't grow at all, and they died. So we knew that if we can target this mechanism, somehow slow down the blood vessel formation, it can help control cancer cells. And that's exactly what this drug called Avastin does it. So Avastin, as some of you may have heard about, is again a protein. It's an antibody. Antibody means a protein that seeks a target. And the target for Avastin is, I don't know what happened. Okay, so this blue thing is the Avastin. So Avastin is this is a tumor, and this is a tumor, and these are blood supplies. This VEGF basically is the factor or the protein that tumor secretes to get more blood vessels on. Avastin, this thing here, is a target against this factor. So we know that if Avastin binds this, it will negate this, and if this protein is not there, the blood vessels won't be able to form. So when Avastin is given, it goes, this light blue thing goes and binds to this factor, and in doing so, what happened? So in doing so, what happens, as you can see, that these blood vessels stop coming or start forming to cover the cancer cells to supply nutrition. As you can see, much lesser blood vessels than here. And the next thing you know, the cancers can't grow because they're not getting enough nutrition that can sustain their growth. And then they die. Okay. The last target, as we talked about, as the cells grow, they are programmed to die in a specific or predefined fashion. The cancer cells, as you know, so these are normal cells. The cells get damaged, they're supposed to die. The cancer cells, however, can avoid this cell death and continue to grow. So there's some research going on targeting this process too. There are not too many medicines available. So just briefly, these are the two medicines which are being worked upon. Here you can see, once again, this purple thing is an antibody or a protein that seeks out these red receptors or markers that actually, they're called death receptors. And the reason they are called that is the moment it goes and binds them, these markers send a death signal to the cells and make them die. So in other words, this process is kind of exploiting the mechanism of programmed cell death. If somehow we can enhance or we can restore the programmed cell death in the tumor cells, that will also lead to their death. And I really want to talk about this drug here. I think many of you may have heard about Kadcyla, is a new medicine for treating breast cancer, just got approved recently. And this is taking those magic bullets or bullets to the next level, making them super bullets. So the monoclonal antibodies, as we talked about, those arrows, we talked about Herceptin, how it goes and seeks out the receptor and binds them and destroy the cancer cells. So what they decided was, if we can kind of attach a payload to Herceptin, so that when it goes to the cancer cells, so this is Herceptin, this is the antibody or the arrow that goes and seeks out breast cancer cells. They attached a little bit of chemotherapy to it. So the whole point being, we know that this thing knows how to seek breast cancer cells. So as it goes and binds to breast cancer cells, if we can add some firepower by adding some chemotherapy to it, would that help? And that's the whole process around that. So basically, this is Herceptin. It finds those markers or the HER2 markers on the cancer cells, goes and binds to it, And along with that, as you can see, these green molecules, these chemotherapy molecules, it brings along with that. And the most interesting thing about this drug is, as it binds to it, as the drug, the antibody with the chemotherapy binds to the marker on the cancer cells, the chemotherapy does not get released. The whole molecule goes inside the cancer cell. This is the breast cancer cell. This is Herceptin, which has chemotherapy attached to it. It goes, binds to the HER2 marker on the surface of the cell. Then the whole thing goes inside. The moment it goes inside, that's when the chemotherapy is released. So and then it explodes and the cell dies. And needless to say, it almost feels like science fiction type of a situation. But this is, again, as I said, those arrows, turning them into next generation arrows, where not only they are going and seeking the cancer cells, they're taking the payload along with that, and the payload is only released once the whole drug goes inside the cell, and in doing so destroys the cell, and once again preventing any damage to the healthy cells. So this drug just got approved about 2-3 months ago, and definitely even ladies who had Herceptin and other chemotherapies in the past, they still responded. More than 50% of the ladies responded when these drugs were given, but most importantly, hardly any side effects, because the chemotherapy was also given, but only to the cancer cells, and that too inside the cancer cells, making it that much more effective. Again, same concept when we were talking about taking payloads to the cancer cells. So along with the Herceptin, the monoclonal antibodies, as we talked about, sometimes chemotherapy can be attached to those proteins. Radiation treatments can be, or a small amount of radiation chemicals can be attached to that too. So the whole point being, these antibodies goes to the cells, and when they go there, they can in this situation release radioactive iodine, so just adding firepower to what they can do otherwise though. This is just an example I wanted to give you. Tarceva or erlotinib is a pill that is used for stage 4 lung cancer. There are 2 types of lung cancers, small cell and non-small cell. Stage 4 non-small cell adenocarcinoma, Tarceva or erlotinib is a targeted treatment. It's a pill that a person takes, as we talked about. There's a small molecule. It goes to those specific cancer cells and interfere with the growth signals. So this is a gentleman who had stage 4 lung cancer, and as you can see, this is the scan before the treatment. You can see there's a lot of stuff going on there. And after being on Tarceva or this pill for almost about, I think this is a scan at around 14 or 16 months, as you can see, a big difference there. Not only it is so effective in controlling the cancer cells, but more importantly, usually we use chemotherapy treatments for management of lung cancer, even though they are getting better, but as we talked earlier, they do have their side effects. So here we had a situation where we did not need any chemotherapy medicines, and just a pill without any significant side effects, and the side effects were some rash and loose bowel movements, which were easily taken care of. You can see a big difference in the scans. Biologic therapy, I know we hear a lot about that too. Just briefly, as you know, we have an immune system. Immune system is a surveillance mechanism that protects us from foreign intruders, and that could be bugs, bacteria, viruses, fungus. So the point was, if we have a mechanism or a surveillance system in our body that can identify something that is foreign to our body, like bugs or infections, could something be done where the immune system can also identify foreign cells, in this case cancerous cells, and in doing so try to kill those? And that was the whole theory about biological therapies, and how we can stimulate and modify the immune system to be able to differentiate between the healthy and the cancerous cells, and in doing so have our own system, something that is inside us, our own surveillance system, try to kill those cells there. You may have heard about the cancer vaccine called Provenge. It was approved a couple of years ago, first vaccine ever to treat cancer. was approved for treating prostate cancer. This is just a cartoon about the schema, the way that vaccine, it's not necessarily really a vaccine as we think about a flu shot or a pneumonia shot. The patient's blood is collected, it is sent to the lab, and that's where these blood cells or the white cells, which are part of the immune system, are modified, transformed to learn to seek the foreign or the tumor cells in a body and to destroy them. And this is what happens. So basically, these are the immune cells from the patient who has stage 4 prostate cancer. They are modified. They are modified where they have the ability to recognize tumor cells or the prostate cancer cells, and in doing so destroy them. So these modified cells are given or infused back into the patient, and they multiply. They can find the prostate cancer cells, attack them, and kill them once again. So we are using a modality to treat cancer which is inherent in our body, our own immune system, and once again not much damage to healthy cells that comes with chemotherapy.
Is that the same thought process of a stem cell treatment that comes from your own? Is that what the thought there is?
Yes and no. The stem cells, just for everybody's benefit, that she's talking about, stem cells are our own baby cells, if I may say, and usually we talk the stem cells and bone marrow transplant, and the bone marrow cells often used interchangeably. A little different there. The concept there is that, especially for malignancies or blood-related malignancies which arise in the bone marrow, the concept there is that we destroy all cancer cells in the body, and then we collect the new baby cells which will be formed in the bone marrow or the stem cells. We collect them and keep them. Then we give high dose chemotherapy to that person to kill all bone marrow cells, and then reinfuse those collected baby or stem cells, so they will go and populate the bone marrow. The principle being that we'll have clean bone marrow or clean baby stem cells and no cancer cells that will be populating the bone marrow, and that way we'll get healthy cells. So that's the concept used in the stem cell or the bone marrow transplant. In this situation, what we are using is our immune system. Immune system as we fight infections or colds or pneumonias. We get a cold, our body makes certain proteins to fight off those bacteria, takes a few days, and we are good. So that is the concept in immune system or biological therapy, where we are giving medicines to train the immune system to be able to recognize tumor cells and then make proteins or chemicals to attack those cells.
Only in research at this point?
I'm sorry?
Is this only in research at this point?
No. See, the Provenge I was talking to you about, this vaccine, it's approved for prostate cancer. It was approved a couple of years ago. So this is now approved. In fact, there are vaccines with the same concept for kidney cancer, melanoma, and lymphomas, which are, very soon you'll be hearing, they'll be approved for FDA too. So kind of next step from experimental too. And then again, as we were talking about boosting the immune system, Rituxan, many of you may have heard about, is a medicine to treat lymphomas. And what it does is it goes and binds to the markers on the cancer cells, and by doing so boosts the immune system to make a response to kill the cancer cells. This is what it looks like. This is what really happens. So as you can see, this is the poor Rituxan tries to kill the cancer cell by itself. There's a fight, but all of a sudden, when it recruits all the immune system cells too, this guy has no chance. So Rituxan plus the immune system, everybody dies. Yes. Okay. So having said that, all these things that are happening, all these advancements, technologies, what has really that led to? So as you can see, there are about 14 million cancer survivors as of January of last year, and at this trend, that number would easily reach 18 million by 2022. And today's day and date, anybody who's diagnosed with any type of cancer, any stage, 2 out of 3 people could expect to have a 5-year survival of about 66%. To put that in perspective, in 1975, that number was less than 40%. And the goal that has been set that by 2020, that number should be at least 72.8%. But I hope it will be much better than that too. Again, these are some of the graphs showing how things are coming along. I'm not sure how well you can read that, but this graph is showing the trend in diagnosing new cancers. And again, I thought that was important too, because when we're talking about managing cancer, one of the main or most important strategy is screening, to find it early. If possible, that can definitely lead to much better outcomes. So as we can see, from 1975 to 2006, there was a peak. Male, both sexes, females, there was a peak around 1990s, and then there's been a steady decline and a plateau there. This graph, the same thing. This is showing actually the number of people who are being diagnosed with advanced cancer. Once again, from 75 onwards, a gradual decline there. This is the 5-year survival, pretty much what I talked about earlier, that since 75 till 2003, the data that we have, around 40–45%, gradually going up to almost 66–70%. 5-year survival. We're talking about 5-year survival, all cancers, all stages, combined. And once again, the death rates from cancers have been steadily declining for the last almost 20 years. So having said that, we still do not understand completely what really is going on. So we have made a lot of progress. Things are getting better. So in conclusion, we have come a long way from where we were. There's a lot of work that needs to be done every day, every week. We hear about new advancements. And I'm sure, God willing, that day won't be too far where it will become more like diabetes, high blood pressure, and the C in the cancer word would not be as scary as it is right now. Thank you so much for your attention.